is Athato Murchapratishedha व्याख्यास्यामः यथोवाचमन्धर्मन्तरिः क्षीणस्य बहुदोषस्य विरुद्धाहारसेविनः वेगाघातात् अभिघातात् हीनसत्त्वस्य पुनः करण आयतनेषु उग्राः बाह्येषु आभ्यन्तरेषु च निमिषन्ते यदा दोषाः तदा मूर्च्छन्ति मानवाः हृत्पीडा जृम्भणं ग्लानिः संज्ञानाशो बलस्य च सर्वासां पूर्वरूपाणि यथा स्वं त्वाः विभावयेत्. Murcha is impaired consciousness, and that impaired consciousness would occur due to the emaciation, and those who have some aggravation of the body contents abnormalities, dosha, and those who do not who consume viruddhahara, and due to vegaghata or trauma, or patients who have psychological weakness, it results in the impairment of the sensory and motor functions of the body, karana and ayatana. These are the two important issues. And bhashya and abhyantara. Bhashya, karana are the panchendriyas which receive the sensation. Abhyantara is the manas, which gives you that connection between the indriyas and the perceptual asset, and the functional motor organs also. Nimishante yada dosha tada murchanti manava. So impairment of sensory and motor activities of the body is considered as the murcha, and the prior to the onset of the murcha, the pururupa of the symptoms could be, there could be pain in the chest, yawning or depression, and impaired consciousness, reduced strength of the body are the pururupa. Samyabhasu nadishu vihitasu aniladivihi तमो अभ्युपैति सहसा सुख दुख व्यपोह कृत सुख दुख व्यपोह च नरः पतति काष्ठवत् मोहो मूर्छा इति ताम प्राहुः. The murcha or impaired consciousness is defined as a situation where the person cannot appreciate something which is comfortable and which is painful, sukha dukkha, which produces the comfort and which produces the suffering. The differentiation between the two are not possible in a patient who is not conscious, and hence unconsciousness is defined as a situation where the perception of comfort and discomfort is not possible. This is Ayurvedic definition, and this occurs due to the obliteration of the samnyavaha nadi, the structures which are responsible for the samnya. Samnya is again a situation where the person can perceive the surroundings and respond to the surroundings. And because it gets either due to the doshas, it gets obliterated, and ultimately it results in involvement of the tamo dosha, and this becomes the murcha or moha. Now, from the current point of view, a state of unconsciousness is again a consciousness is defined as a state of being aware of the responsive to one's surroundings. So absence of that, a person's awareness or the perception of something, and the fact of awareness by the mind itself is the world. So that's the issue. Because you are alive, and if you are, because you perceive the world exists. If you do not perceive, the world is of no consequence for you. So definition of consciousness is a state of being aware and responsive, is what the current science would say. So when you are not able to be aware of the surroundings, that is considered as the unconsciousness. According to Ayurveda, the awareness of your perception, direct perception of the surroundings is the pratyaksha, and the pratyaksha would occur due to atma indriya manortharam sanikarshat pravartave sukha dukkham anarambhat atmasthe manasi sthire निवर्तते तदुभयं वशित्वं च उपजायते सशरीरस्य योगज्ञाः तं योगं ऋषयो विदुः. The yogajna are considering the situation where atma, the soul, it connects to the indriya through manas, and that's what we call as indriya artha sanikarsha, and that results in perception of the sukha and the dukkha, comfort and discomfort. So there is the pathways of the sensory perception would be, according to Ayurveda, there is the sensory organ, the light object, and that is received by the sensory organ, the eye, and then it reaches to the Atma. Now, from the current science point of view, Atma is not known, perception of Atma is not known, but we know that there is a passage of these impulses into the different areas, integration areas of the brain up to the level of cortex, and then the cortex would perceive like what is that sensation. The different zones of that perception are now identified, though the concept of Atma is not there. So the Nadi, Sanyavaha Nadi, they are now known. Then Indriya Artha Sanikarsha is also known. Only in that context, the Atma is something which is not conceived by the contemporary science. So that soul or Atma is what I am, that perception, that itself is not known in the contemporary science. Anyway, the Samya Nasha, according to Dellana, the definition again the same, Sukadukka Vepoha Krita, Sukadukka Nasha Krita, the person who cannot perceive both pain as well as the comfort is considered as the unconscious or murcha. Now, consciousness by itself would have mainly three components: awareness, alertness, and attention. This is how the psychology describes the consciousness. Awareness is a status in which knowing, perceiving, and being cognizant of the events exists. So when you are aware, like what's going on around the area, that's the awareness. Alertness is in a state of active attention, high sensory awareness, and readiness to act. See, simply being knowing about the surroundings is something, but having more intent in attention over the area and ready to act is the alertness. Attention is the ability to actively process the specific information in the environment while tuning out other details. So when you are able to select what you need to know, like when you are attending the class, the subject which is being discussed in the class only is perceived, though you are aware of the surroundings. That is the attention. These are the three important aspects of the consciousness according to the contemporary science. And the impaired consciousness now is described in these terms, like awake is fully awake, confused is the next stage where person is unable to think and judge rapidly and clearly, and even if the patient responds, the responses would be inappropriate. Like when those who are sitting in the classroom and they are just thinking about something else, and when some question is asked, they are not able to answer the question as such. That's the confused state. Lethargic is the disorientation of place and time, like impaired memory and loss of self-recognition, where the person is not able to know exactly where he is and what the time part as such. That's the lethargic situation. Obtundation is other term used now, where the patient responds to only the superficial stimuli, and pain, of course, not necessary. He responds to the pain too, but for assessment criteria of obtundation is even not painful, painless stimuli also. Patient responds, wakes up, responds to the stimulus, and again sleeps. Stuporous is deep sleep, where the response to strong or painful stimuli only. Comatose, where the person cannot be aroused. These are the different terms used for the impaired consciousness in the contemporary situation in the psychology or psychiatric practice. Of course, there is one more of the situation word used as syncope. Syncope is a transient loss of consciousness due to temporary causes, where the condition is reversible. Now, the same different types of these grades of impaired consciousness are described in Ayurveda at different levels. Murcha is that level where the person goes into a situation where the impairment of the consciousness would occur and the person would not be able to perceive anything around the surroundings. And Murcha, Pitta Tama Praya, Raja Pitta Anila Dubhramaha, Tamo Vatakafa, Tandra, Nidra, Shleshnatamo Bhova. Tandra, Nidra are the other terms used like Indriyartheshu Asamvittihi Gauravam Jimbadam Klamaha, Nidrarthaseva Yasya Tasya Tandram Imidishetu. Tandra is a lethargic situation where the patient feels sleepy and he is not able to perceive the surroundings, he is not able to know the time and other factors. Dosheshu Madhumurchaya Hakta Vegeshu Dehinam Swayameva Pushamyanti Sannyasa Naushadhevina. Sannyasa is the deeper level of consciousness where the person would go into a deep unconsciousness and the patient may be aroused only with some medical intervention. Otherwise, the patient would not be able to recover. That's sannyasa. So the same what we have discussed in the contemporary psychiatric world, similar things are described in Ayurveda as Tandra, then the Sannyasa, Murcha also the next part, and then the Vaddeham Asam Chestam Akshipya Atibalah Malaha Sanyasyanti Abalam Jantum Pranayatram Ashidaha Sana Sanyasa Sanyastaha Kashti Bhutam Rupama Prani Ruchite Shigal Muktva Satyapalam Kriyam. Sanyasta sannyasa is a more deeper sannyasa where it may be fatal, where the person would not be responding to any stimuli, and that's a comatose situation where, and ultimately he is very close to the death, and if not handled properly he may even die, and the vital functions also can be affected. That's the sanyasta sannyasa, which is a much deeper variety of unconsciousness, coma as such. Now, as far as the consciousness grading is concerned, the level of consciousness and the purpose of consciousness, again, Ayurvedic description, you have a very elaborate description. As far as the conscious and conscious activity are concerned, Ayurvedic description is much above, much more than what the contemporary psychiatry would say. And I just gave a simple issue. Now, as far as the whole creation of the world is concerned, what the Buddha says, Mahabhutani Ahankara Buddhi Avyaktameta Indriya and Dashayikecha Panchachendriya Gocharaha. The sensory perception would be developing from the basic idea, basic situation, a non-creation or absence of the creation, Mahabhuta, Panchamahabhuta, and there is a self-awareness, and that creates the intellectual capacity, and that intellectual capacity would be able to connect to the sensory organs and perceive the situation. And the signs of life, signs of the activity would be Ichha, Dvesha, Sukham, Dukkam, Sangadaha, Chetana, Dhrutihi, Etus Kshetram, Samasena, Savikaram, Dahram. These are from the Bhagavad Gita, not from Ayurveda. Bhagavad Gita shloka, where that evolution of these are described methodically. Contemporary this physiology would attribute all these evolution to the central nervous system, where again the similar issue is described like a central nervous system which results in sensory and sensory motor, perceptual motor, and cognition, which is related to the intellect, the systematization, development, and the intellect, ultimately the intellect. Ichha, Dvesha, Sukham, Dukkam, that's the intellectual capacity is the ultimate. And as far as the description and authenticity of the description of these are concerned, our epical description or Ayurvedic description, or maybe whatever is mentioned in the Indian epics, would be much more relevant than what the contemporary science would say. Anyway, coming back to the physiology, a physiology of unconsciousness or conscience would be where the structures, now from the science point of view, contemporary science point of view, Atma doesn't exist. Manas, it's not understood what is Manas as such, but all that would be attributed to the physical structures. So from that point of view, now I am limiting to that part, like what the contemporary science would say. The most important structures of the brain which are involved in the consciousness are the brain stem and the reticular formation, reticular activating system. While the cerebral cortex is the area where ultimately the sensory situation is reflected, and the meaningful actions are created by the brainstem and reticular activation system, which regulates the input in. Thalamus and hypothalamus also would be the mediators which correct or modify the input from the periphery. The projection pathways, ascending pathways from the sensory periphery are those motor sensory perception, where the person will be correlating to the surroundings, and these are the important structures related to the consciousness from the physiology point of view. But ultimately the wakefulness and sleep, or wakefulness and unconsciousness, is attributed to the main neurotransmitters, the most important neurotransmitters which decide like whether you are wakeful or sleep. Now sleep, unconsciousness, coma, these are all, and anesthesia, these are all somewhat resembling conditions, but there is a lot of difference between them. Sleep is a natural physiological changes which occur in the neurotransmitters as per the current biology. And the major important neurotransmitters are GABA, acetylcholine, monoamines, and drexin, and their location at the different areas and what happens in the wakefulness and the sleep. During sleep, GABA would be increased, enhanced, whereas in wakefulness, the GABA would be comparatively lesser or it doesn't get activated. And acetylcholine would be activated more during the wakefulness, and during the sleep that activation would be lesser. So due to that, this is how it is assessed. This nidra, which we consider as tamo avarana, that tamo avarana is maybe explained from the current science point of view of the changes which occur naturally in the neurotransmitters. But these neurotransmitters can be modified. The functions of the neurotransmitters are actively modified in a general anesthesia. General anesthesia is defined as a state of controlled unconsciousness, unconsciousness which is under the control, and it can general anesthetics produce a widespread neurodepression. They produce the neurodepression or modify the activity of different neurotransmitters, and hence they are categorized into different categories like dissociative anesthesia, or maybe the sedative anesthesia, tranquilizers, and so on, and without shutting down the brain. So that's because it is reversible and controlled. Anesthesia is a reversible and controlled status of unconsciousness. Now, the neurotransmitter effects of different commonly used drugs like halothane, propofol, enflurane, isoflurane, these would be acting on the GABA receptors, whereas ketamine and nitrous oxide, xenon, they act on NMDA receptors. Glycine receptors are potentiated by halothane, propofol, enflurane, so on. So the difference between the sleep and anesthesia. Sleep occurs normally, which occurs as a physiological condition, which modifies the activity of the different neurotransmitters. Anesthesia is a controlled situation where again the similar issue. The neurotransmitters are modified in a controlled manner with the specific drugs, targeted drugs, and that's how the general anesthesia is developed. Now, when a patient comes to in an unconscious condition, what happens? Now, how to deal with that patient who is brought in an unconscious condition? The first of the thing which you have to do is see whether the patient can be having his individual breathing, that he is able to survive or not. The vital functions of the breathing, cardiac pathology, arterial pressure, they have to be noted. If that's not in a proper situation, if the patient is not able to breathe on his own and the blood pressure is not within that viable limits as such, then the patient requires an immediate attention, and you will have to go for immediate life support systems. That's the one. And if the patient is having that vitality, then measure the capillary pressure. Like you just see whether the patient can have that blanching sign over there or not. Look at the pupils whether they react to the light or not. And the Glasgow Coma Scale is assessed. Now, Glasgow Coma Scale, I will come to that part in detail again. We have discussed it many times. Glasgow Coma Scale is assessment of the consciousness at different levels, and the total awareness score is 15. And if the score is less than 8, the patient requires life support. If not, then you will have to he can maintain the patient on his own without the life support as such. Now, from the general protocol of dealing with the unconsciousness, if the patient is in a viable situation, the first and foremost thing which we have to do is treat for hypoglycemia. You look at the possible situations of the glucose level, which because it is the most common, hypoglycemia is the most common cause for the unconsciousness clinically. Then or you study for the maybe the toxicities. There could be some toxic substances, and if there is a history of toxins consumed, then the antitoxins may have to be given. Then if the patient is viable, pupillary reflexes are normal, and in that situation, and the patient otherwise is somewhat responding to the stimuli, then you go for the detailed history, have an intravenous access, and go for the different blood tests which could be assessing the cause of the unconsciousness. And maybe if possible, get a CT scan of the brain to see whether there is any cerebrovascular pathologies or not. So a detailed diagnosis approach is to be done, and then once you have made the diagnosis, then go for the particular treatment as such. Glasgow Coma Scale, as I said about, I think it's very well known, but again I will repeat that it's mainly based upon the 3 levels of assessment: eye opening scores, and motor response scores, and verbal response scores. Now, eye opening scores are patient has no response of eye opening, then score is 1. If the patient opens the eyes and looks at the surroundings, then the score is 4. In between, you have the patient eye opening for pain or eye opening to verbal command as 2 and 3 as scores. And best motor responses, if there is a patient is able to obey your command, like ask the patient raise the hand or leg or so on, then the score is 6. Then if the patient is able to locate the area of pain, score is 5. If the patient flexes the body when there is a painful stimuli, the score is 4. Flexion is not normal, and it's not directly as such. That could be decorticate. Again, consider decorticate, decerebrate. Decorticate is where the patient's response, flexion response of the body. Flexion response is when you produce a painful stimulus, the patient retracts that part of the body from the source of the pain. That's the normal situation. And in a patient with the different levels of unconsciousness, either it could be an abnormal flexion may occur, but it is not normal. Instead of flexion, it becomes extension. Then it is the decerebrate, much deeper level of unconsciousness. If there is no response, score is 1. Similarly, verbal response scores, if the patient is able to speak, is 1, and if there is no response, 0, 1 as such. Now, this score is one of the important issues by which you can decide like whether the patient requires a life support or not. If the score is less than 8, essentially the patient requires life support, and it's one of the essential part of the clinical assessment. Now, if the patient is already on a tube, endotracheal tube, where the patient verbal response cannot be assessed, then the score has to be maintained with the suffix T to convey to the others. The Glasgow Coma Scale may not be applicable at the same level for the pediatric condition in children, because the verbal responses of children and motor responses of children may also vary, and hence there is a modification of the Glasgow Coma Scale in the pediatric practice, and depending upon the age 1 year or older and age 0 to 1 year, the responses would be for eye opening. Spontaneous, of course, is in the very young children. The child may not understand your verbal command, but eye opens the eye at shouting, and pain or no response. That's how it is modified. Then best motor response, you do not expect a child to respond to your commands at 0 to 1 years. Only after a year or so you may be able to expect that. So that's the issue. Rest of the things are the same. And for the verbal responses, a child cries appropriately, properly for the stimulus. Like if there is a painful stimulus, cries, or when the child hungry, it cries. And for the verbal response, again, do not expect the child below 0 to 2 years to respond verbally. The only response will be crying or screaming. So with that, the scores are modified. So pediatric Glasgow Coma Scale is just a modification of the observations. Rest of the things are the same. Now, another way of grading these would be unconsciousness would be grade 1, 2, 3, 4, depending upon the grade 1 is awake and the patient is able to respond to the stimuli, the particular touch stimulus also, and able to converse, and the patient is able to follow your commands. Grade 2 is response to pain but not voice, and grade 3 is unresponsive to the pain also. Grade 4 is unresponsive to pain, and there is a flaccid paralysis. Reflexes are also absent. Even the respiration may be compromised. Cardiovascular sites are decreased, and that's the condition where the condition will be critical. So grading of the unconsciousness is done popularly by the Glasgow Coma Scale, or the other way you may have the other grading also. The common causes, differential diagnosis of unconsciousness as per the current situation would be mainly categorized as neurological, metabolic, and diffuse physiological brain dysfunctions, temporary dysfunctions of the brain, or psychiatric origin. And the causes could be neurological, it could be ischemic stroke, or it could be cerebral hemorrhage, subarachnoid hemorrhage, subdural hematoma, brain tumors, cerebral lymphomas, multiple brain metastases, central nervous system infections like meningitis or so on, cerebral abscess, cerebral edema, hydrocephalus, anoxic brain injury, that's that the patient has a cardiac arrest and hence the brain has become injured, and encephalopathy syndromes, different sorts of encephalopathies, and trauma. Metabolic causes like hypoglycemia, hyperglycemia, the two most common conditions of unconsciousness which we see clinically are the abnormalities of glucose metabolism and hyponatremia or hypernatremia, hypercalcemia, Addison's disease, hypothyroidism, uremia, hypercapnia, septic encephalopathy, hepatic encephalopathy also can be a cause for this. And physiological brain dysfunctions are like seizures due to any convulsive pathology, epilepticus like status epilepticus, alcohol, opioid, drugs, many of the drugs which can produce poisoning, hypothermia, or the serotonin syndromes. Psychiatric conditions like psychiatric coma or malingering also could be a presentation of the unconsciousness. And from Sushruta's point of view, the unconsciousness or murcha is categorized into 6 types. Vatadibhi, Shoditena, Madhyena, Vishena. Madhya is the toxic category. Visha also is the same category. Vatadibhi, Shoditena, Vatadi dosha, Vata, Pitta, Kapha, and Rakta. Shatsvepi, Eteshu, Pittam, Hi Prabhutvena Vadishtade. In all the status of unconsciousness, the most important dosha would be Pitta. Apasmaroktalingani, Tasam, Uktani, Sattvaha. The clinical symptoms are comparable to that of the apasmara mentioned in the previous chapters, like Prithvi Amorupam Rakta Gandhascha Tanmeha Tasmad Rakta Segandena Murchanti Bhuvi Manavaha. Because of the involvement of Mahabhutas, of Prithvi Mahabhuta, Jala Mahabhuta, which also results in the formation of the blood, the major component of the blood there. So circulatory pathologies would be one of the most important factors in a patient of unconsciousness. The most important factor according to Sushruta would be the Pitta and Rakta particularly when it is not circulated properly, and hence the patient would have a feeling or smell of blood in the nose, and Rakta Segandhyena Murchanti. Due to the smell of the blood, the patient may fall unconscious. Dravya Svabhava Ityeka Drishtva Yadabhimshyati. Certain of the people may just see the blood and then fall unconscious. Gunaha Tivratarpena Stitastu Vishamadhyavyoho Saeva Tasmat Jayeta Mohastabhyam Yatheridaha. The Madhya and Visha, they are very Tikshra Dravyas, and they harm the metabolic functions of the body, and hence they would produce the unconsciousness. Of course, a patient with the alcoholic intoxication or the other way may present in a stage, in the initial state of agitation, or later he may go into the sedation scale. So, majority of the patients of factors of unconsciousness like cerebrovascular accidents, hypertension, or many times the toxic pathologies may not present with the unconsciousness in the beginning. Initially there could be a stage of agitation, then it may result in unconsciousness, and hence in certain of the patients where Glasgow Coma Scale becomes irrelevant when the patient is present in the agitated state, we follow another scale, that's Richmond Agitation Sedation Scale, which can predict about, particularly this is true in case of alcoholic patients or patients, drug intoxication patients. This is absolutely relevant, and that scale is mentioned as the plus or minus plus 0 to 4 for the agitation, where the patient will be restless, agitated, very agitated, combative, or in the downward trend, the drowsy, sedation, moderate sedation, deep sedation, and cannot be aroused. And this kind of scoring is very relevant in case of drug intoxication or alcoholic pathologies, or maybe the other causes of unconsciousness where before the patient becomes unconscious, there will be a state of agitation, and the patient may be brought to you at that early stage of agitation where you can predict about the next complication. And it's in case of alcohol, it's quite true that a patient who has gone to the score 4 plus score will go next into the minus side, and that rate of change from the positive to the negative would also give you some idea about the severity of the pathology. Anyway, that's the other thing. Now, the assessment of a patient who has come with the exam, unconsciousness, we follow the Glasgow-Coma scale where you assess that visual responses, verbal responses, motor responses. Now, what Sushruta has said is almost on similar line. The assessment would be Stabda Angaha, Drishtihi, Gudha Uchvasaha, Murchidaha. The Murcha patient would be having Stabdangaha, motor disability. So, assessment of the motor abilities, motor function is one of the criteria. Drishtihi, visual abnormalities are incapacities of the vision, and hence that has to be assessed. And Gudachvasa, respiratory assessment. The assessment of the respiratory function is the vital. So, Sushruta's scale of assessment is much better than the Glasgow-Coma scale, where the vital functions of the respiration is assessed. And that would give you an idea about the severity of the unconsciousness. The same factor which I just referred earlier, like a patient of alcohol becomes agitated and then he becomes unconscious. You mentioned in the Samhita, Madhyena Vilapam Chete Nasta Vibranta Manasa Gatrani Vikshipan Bhumo Jaram Yavatra Yati Tat. A patient of alcoholic intoxication may initially have agitation, where the patient may have irrelevant speech, and then he falls down, and then he becomes unconscious, and he will go into the deep unconsciousness even. Vepatu Swapnatrasha Sihu Stambascha Vishamurthide Veditavyam Tibrataram Yathastvam Vishalakshanihi. In case of the Visha, other poisonous condition, before the patient becomes unconscious, there could be tremors, or there could be trishna, excess of thirst, and then the impaired movement, and then the unconsciousness may occur. So, that pre-unconsciousness agitation, so that agitation and sedation scale would be relevant in these two conditions according to Sushruta. Sekavagaho Manaiha Saharaha Shitaha Pradeha Vedananilascha Shitani Panani Chigandhavanti Sarvasu Murchasu Anivaritani. The first aid, primary treatment according to Sushruta in all cases of unconsciousness would be exposure to the cold and application of any cold substance like cold water application, or sprinkling cold water on the body, or keeping money, that's precious stones which have the cold property, or Shita Pradeha, application of cold these lepas over the body, or fan having Vedana Anila, this cold air is to be exposed. That would be the first aid in all cases of Murcha, or even substances which produce a smell, pungent smell also is one. Of course, in the recent medical practice also, in the contemporary medical practice also, till very recently, till maybe 90s, like one of the usual first aid was ammonia given into the nose to make the patient awake. Now these days it is not done because we have now better drugs. So use of ammonia now is not a practical thing or relevant technique now in a patient of unconsciousness. But earlier it was a relevant technique where because of the pungent smell of the ammonia, patient would wake up. Then the other remedies would be Sita, Prayala, Ikshurasaputani, Draksha, Madhuka, Surasanmitani, Kharjura, Kashmaja, Rasesutani, Panani, Sarpimsa, Jivanani. If the patient is able to drink, then give a Jivaniya Kashayas and the Jivaniya Panas, and they are mainly having sweet substances, fruit juices of different categories, which will be producing the nourishment would be the other way. But important is the patient should be able to drink, like the drink semi-conscious, and if the patient is able to drink, give some nourishing food. Siddhani Varge Mudhire Payamsi Sudadima Dangraja Harasascha Tatha Yavaha Lohitashalayascha Murchas Pratyascha Sadasatinaha. The other Madhura Varga Siddha milk or that Dadima, Jangala Samansarasa, Rohitashali, that Raktashali, these are the Pakya. And Satina Dhanya. Satina Dhanya is the natural seeds also considered as the Pakya in the unconscious. But all these are relevant if the patient is having that swallowing reflex and oral fluid can be given. In the present day situation, we prefer to give the patient either IV or a rail tube feeding, gastric tube feeding, so that the possibility of aspiration in a patient of unconsciousness is not there. So that modification has to be accepted, but with the rail tube you may give the same medicines, right? Bhujanga pushpam marichani ushiram kolasya madhyam cha pibetu samani shitena toyena bisamranalam kshaudrena krishnam sitaya cha madhyam. The other drugs which could be given are the same of different categories of drugs, Nagapushpa and Ushira, Kola, etc., which are Shitavirya and Brahmana Dravyas. Kuryakta Nasa Vadana Avarodham Kshiram Pibedvapi Atam Anushinam Murcham Prasaktam Shirovideki Jayed Abhiksham Womanesh. If the patient is not able to drink, then Sushruta suggests Nasa Vadana Avarodha, blocking the mouth and the nose, so that the patient would again start breathing. This is one of the techniques suggested. Of course, from the current point of view, I would not suggest that technique, like blocking the nose would not be helping in the stimulus, but in a patient who is otherwise like malingering or psychological unconsciousness, this would make the patient breathe well, and then the patient becomes conscious, apparently becomes conscious. That apparently unconscious patient, where he suspects some psychiatric pathology, to make the patient alert or to make ensure that the patient gets up, this would be a better technique. Otherwise, in all other conditions, of course, I would not suggest the same Nasavadana Avarodha. Blocking the mouth and the nose would not be a proper technique from the current point of view. Or the other options are Manusha, the milk of human beings also can be given, and Shiro-Vilijan Dravyas and Vamana Dravyas also are suggested. Haritaki, Kwathashadam, Ghadam, Dhati Palaram, Sarase Kadama, Draksha, Sita, Dadima, Lajavanti, Shita, and Nilotpalapadmavanti, Vivek Kashaya, and Segandavanti, Pitta Yani Shamam Nayanti. All the protocols of the treatment mentioned in the Pitta Jara, as well as the specific yogas mentioned, which have the Madhura Rasa, Brahmana Gunas, are suggested. Prabhuta Dosha Tamaso Atirekata, Samurchita Neva Yudyaha, Sanyastu Samyo, Brasha Dushtikitsyo, Jayastuda, Buddhimada Manushaha. If the patient is in a deep comatose condition and cannot be awakened at all by any of the stimulus, that's considered Sanyastu Samya, or what I already we have discussed, Sanyastu Sanyasa, and let's say incurable. Yatha Amalosam Salile Nishiktam Samudharet Ashwalinameva. Tadvat Chikitse Toraya Bhishaktam Asvedanam Mrityavasham Prayatam. Now, such a patient is an acute emergency, and only when you go for a immediate emergency treatment, that Sushruta has compared this to a situation where a moist ball of mud, a mass of mud is kept in water, it gets dissolved immediately, within a short time it gets dissolved, and the handling that mud ball in water is a very skilled job, very difficult, or salvaging that mud from the water is a difficult thing. Similarly, a treatment of unconscious patient also is a very skilled job, and it requires an immediate reflexes, very fast reflexes. Tikshna Anjana Abhyanjana Dhumayoge Hitusa Nakhabhyantara Totrapatihi Vaditra Gita Anunayehi Apurvehi Vighattanehi Gupta Palavadharshehi. The other stimuli which can be used for making the person wake up from a comatose condition would be Tikshnanjana, the application of the coryllium into the eye, Abhyanjana, application over the body, or Dhumapana, Dhuma Yoga, the inhalation of irritant substances, or pressing at the base of the nails, Nakhabhyantara Totrapati, or pinching the nails, which would be very painful, or external stimuli of producing some music or sounds, etc., or handling the dental organs also would be the other methods by which the patient can be stimulated. Abhi kriyabhischa nalabdha sanyah sa anaha lala shvasanascha varjyah prabuddha sanyam. Now, if none of these, any of these would not be able to make the patient awake, then or the patient has a distension of the abdomen and there is salivation and the respiration is blocked due to the saliva, that condition is incurable. Prabuddha sanyam vamananlomehi tikshnehi vishuddham lagavatyabhuktam palatrikehi चित्रक नागराढ्यैः तथा अश्मजातात् जतन प्रयोगैः सस्यकरैः मासम् उपक्रमेत विशेषतो जीर्णघुसं च सहायः. Once the patient has become awakened, then you may have to give vamana, anulomana or laghu patya ahara, and for a month you have to take care of the patient. And jirnaghrita, the old ghee, is the other preparation. यथास्वं च जलग्नानि कषायाणि उपयोजयेत सर्वं मूर्छापरीतानां विषजायां शापहम्. In the Jwaragna kashayas also are suggested, and in all the murcha, the visha chikitsa also could be followed. The principles of visha chikitsa also have to be followed. With this we come to the end of the chapter. It is Sushruta Samhitayam Uttaratantrante Kaya Chikitsa Murchapratishedha Nama Ashtamodhyaya Aditah Shatchatvarinchatamam Adhyayah. With this we will conclude. If there are any questions, we will try to answer. There is one question. What is meant by term hard problem of consciousness, first coined by David Chapman? Okay, that hard problem of consciousness is where the patient would not be able to respond to the stimuli easily, and it is now in neurosciences they do use that, like when a patient is not able to respond to the stimuli properly, though the patient is fully conscious. Now your vital functions are normal, but patient is not able to respond to the stimuli properly, which could be like a disorientation. That is often named as the hard problem of consciousness. Right. Okay. Right. Anything else? So, no other questions. We'll wind up.